I first got interested in the area of pain and suicide when I was asked to be part of a panel examining some of the root causes of the burgeoning problem of unintentional opioid overdoses. And I asked this simple question: how do we know that they're unintentional? These are very brittle people. They have suffered from significant depression, multiple losses in their life. And how can we assume that all of these, quote, unintentional overdoses are truly unintentional? That sparked my interest into starting looking at the data. And interestingly, there's been a number of different studies done on pain and suicide. There have been many studies on the area of pain and suicide, and about 20% of patients that suffer from chronic pain have at least passive suicidal ideation. About 5 to 10% have active, and 5% have plans, and 5% have attempted suicide. So the issue is, in a busy practice, whether it be primary care or a busy pain practice, how can you assess suicidal ideation, and what strategies can you embed in your practice to mitigate some of these risks of suicide, or at least be able to identify patients at high risk and then refer them to the appropriate treatment. The majority of patients with chronic pain are treated in primary care. They have the least amount of time and resources to deal with these complex cases. In patients who are emotionally brittle, there are a number of tools that can be utilized to assess depression and risk of suicide. I always suggest to primary care physicians they use ones that are very brief and easy to score, and that give them a good picture of the patient. I also suggest that a clinic, a very busy clinic, has a strategy to deal with these. I mean, how can we mitigate some of the risk of suicide? Well, some of the risk factors for suicide include poorly controlled pain, so we need to be more sensitive about making sure that the pain is controlled. Other risks include isolation, so it's improving their social status, even getting involved in support groups, for example. Looking at past history of suicide attempts or family history of suicide attempts. So if someone has had a past history of a suicide, they're at higher risk. So once we mitigate and we assess their risk once we assess and establish their risk of suicide, then we need to sort of develop a plan of action. And that means being able to have the mental health group in your community on speed dial. It's being able to get the family involved if necessary. If they're on opiates, it's giving them a limited supply that a family member will manage to mitigate the risk of an overdose. And that you work within the community to develop the interventions that will be helpful, because I guarantee you the majority of people with chronic pain suffer from depression, and a subset of those patients have suicidal thoughts.